Hi, my name is Peter. I'm a specialist in emergency medicine from Denmark, working in Stockholm. And um, this is a lecture or lecture series that I gave as part of being the head of education for residents in my hospital. And well, our themes for this week was shock and chest pain, and then we did a journal club and the advice trial, which I will be going through in part two. So we'll jump into the first part about shock, and then we'll go through some of the literature and advice on chest pain. All right. So before heading into this lecture in general, one of the other themes of this lecture series or this week, because we also do a lot of blood gas and ECG and point of care ultrasound. One of my favorite non-technical skills to remind people about is the opportunity cost, because many of the things that we do, whether it's ECG, POCUS, or blood gas, especially in the very sick patients like the chest pain patients that might have an aortic dissection or the shock patients, it's not wrong to do a blood gas. It's not wrong to do a ECG or a POCUS. In fact, it's really important to use these tools. But there is a time and a place for each of them, and there's a time and a place for when even on the surface not a dangerous test, not dangerous for the patient, like for instance an ECG. It's not dangerous per se. It might lead to a little bit of overdiagnosis sometimes, but in general, it's not a dangerous thing to do for the patient, and it's a low yield, good test. But even a good test that is harmless or almost harmless will, in the setting of a time-sensitive, critically ill patient, um, that will be time spent on that we cannot use on something else. And it also goes for not just taking the ECG, but also over interpreting it. We can use our tools, but there's a certain amount of data we can get out of it, and I'm not saying where to draw the line. It's often a case by case discussion, but we should be aware that there is such a thing as over interpreting your AVG or your blood gas. Um, and I'll just give an example of what I kind of, when it comes to, for instance, blood gases. I'll give an example of it shortly. In POCUS, I believe this as well. I mean, you can do an ultrasound of the entire body each time that you have a patient that is critically ill, and that might sometimes be appropriate, such as the Roche exam. But um, depending on what you suspect, what your pretest probability is, and how you think that this tool might help you, and how other tools might be faster or better or more definitive, you might not want to get the exactly the best heart view to be able to measure TAPC or some of these things. You might be able to just eyeball it and see it's not huge. The right chamber is not huge, or some part of the another part of the POCUS exam is not obviously problematic, and then you can move on. But sometimes, of course, if you have a high probability of a pulmonary embolism in this patient, and then you need to thoroughly examine the right chamber so to make sure that it's not a big problem, then it's another thing, right? So you need to kind of use these tools according to your pretest probability, and there is such a thing as too much emphasis or over interpreting things, or over using your time that could be spent on something else, making a more definitive test, such as a CT scan. Okay. So that's the thing about the opportunity cost. Things that you could use, like time you can use on one thing is used on a low yield thing instead. And yes, so I will do a lecture on blood gas analysis at some point. Um, but just as an example, I think there's a law of diminishing returns on blood gas analysis. I think there's such a thing as well on POCUS, and I think there's such a thing as well on ECG. When that is said, I am impressed with the people who are like deeply ingrained and expert at these tests like POCUS or ECG. It's amazing to see what you can get out of this, but most of these things that experts can squeeze out of the ECG is something that in most cases can be found out in other ways, or by taking a new ECG in 15 minutes oftentimes. So it depends, right? But you don't have to, as an emergency physician, you don't have to be expert on all of these things. Like you have to invest the time to be good at a lot of these things. But there's such a thing as, like, at some point, the more time you invest in this, there's a law of diminishing return. And also in the clinical situation where you have a patient in front of you, there is a law of diminishing returns when it comes to interpreting the tests, right? You can squeeze a lot out of the ECG just by checking the, as I talked about in the ECG lecture that I did a few years ago, the OPQRST, or doing a syndromatic read-through. As it comes to, for instance, the ischemic patient, when you're concerned of ischemic chest pain, when you will do an ACS or OMI read-through of the ECG. That's definitely something that is on this like green slope or green area of this. But at some point you will be over-interpreting, or like at some point you will be using too much time on the test, so that you might need to move on to something else with this patient, and that's where opportunity cost lives over here, I think. So for blood gas analysis, I think basic analysis of the blood gas, very important. Also, being able to do anion gap is essential, I think, as well for the emergency physician, and be able to interpret that and accordingly kind of categorize the patient into HACMA, NACMA, and so on, and know what the causes of low anion gap is, such as, I said lumps here, but it's limbs, like lithium ions, myeloma, and so on, low albumin, and so on, like these things, right? Because this helps in the encounter, and you can have a pH that is normal, like no acidemia or alkalemia, but there's an acidosis hidden, which you can find by reading the anion gap. And this is my personal opinion, but I think that this, and I have tried to delve into the Stewart approach for a long time. And I think I've understood most of it, and I've tried to use it clinically, but I've never been truly convinced that, at least in the emergency department, in the first couple of hours of the patient's stay in the hospital, I'm not sure that is within the wheelhouse of emergency medicine. But if you're an intensive care or doctor that, like just Scott Weingart, who also like believes in the Stewart approach, I believe then you can then there might be I can see how it's alluring, and that you can measure a lot of these things, and maybe you might give them a little bit. There's an argument that you might get a more perfect reading of all of the hidden and not hidden blood gas problems, right? Acidosis and alkalemias, but I don't think they're, for the most part, clinically relevant, and I like maybe 95% of the times I would do fine with just doing the anion gap and the basic blood gas analysis. But moving beyond that will, for me at least, take a lot of time, cost more blood samples than I need, and instead of like doing this detailed analysis, which I will come to might not be better even, I would rather just correct what is wrong, try to correct the things I think is wrong through the basic analysis, if they have a HACMA, like a high anion gap metabolic acidosis, then use the cult mnemonic, like ketones, take ketones, uremia, take the creatinine, lactates, calculate or see if the lactates are the reason why the patient has a high anion gap metabolic acidosis and what the causes of that would be, and then the T toxins, like do they have metformin, do they have metabolic or toxic alcohols such as methanol or ethylene glycol. So if I correct that and then I redo the blood gas, and like even if there's a hidden somewhat an inappropriate compensation, then I will usually find it. Or if there might be a hidden metabolic alkalosis, then I will probably find that as well. Or even if I don't find it, I will at least usually the cause of this is giving, like the treatment is giving fluid to the patient, and I'll do that anyway. So doing what is best for the patient as according to the primary blood gas problem, and then retaking a blood gas, I would say in the emergency department, is almost always better than doing the Stewart's approach. Now, depending on the context, if you're an ICU or a doctor in what is called EMI or a step-down unit from the ICU, then yes, maybe it is important to do the Stewart's, but I mean, I'm not totally convinced about that either. But I'm not that kind of doctor, so I remain to be convinced by the literature on that. Okay. There are some great resources for blood gases, and there's a colleague of ours who does this, or two colleagues of ours do this bloodgas.se, which is a great Swedish site for this. You can check out another Swedish site if you want to do the full Stewart. And this is an emergency medicine podcast /blog where they've gone full Stewart. And if you want to check that out, you can, and you should. Don't trust me for what I'm saying. Try to make up your own mind, of course. But I think the best blood gas analysis on the internet there is Sarah Krager's, and that's kind of the one that I'm using and that we're kind of adapting in the EMCC, or at least a version of that, where it's like a Stewart's light for these very rare blood gases where there might be an advantage of doing the kind of a Stewart approach, but for the most part, it's anion gap for me. Okay, moving on to shock. So to start off, the definition of shock, and this I have from the IBCC homepage, and again, most of this is from conglomerate of the IBCC, sepsis, and undifferentiated shock homepage. It's from different. It's from Sarah Krager's lecture on this, on the shock, the new shock paradigm, and it's from different other sources that I have on the acutmedicina.dk. So the definition of shock is a state of systemic hyperperfusion with inadequate blood supply to the tissue. Unfortunately, this may occur in different ways. So kind of like shock can present both with normal blood pressure, for instance, or low blood pressure. Like it's more like a puzzle, where the more puzzle pieces you have of the puzzle that are bad, the more likely this is actually shock. And there are some puzzle pieces that are more important than others, and we'll go through those. The importance of promptly diagnosing shock and discerning its cause cannot be overstated. This is again from IBCC. Unfortunately, shock may present in a variety of ways, so diagnosis isn't always so simple. This is from Sarah Krager, and she has this picture where we as a physician are looking at our patient who are swimming. So there's an inciting event that makes the patient physiologically stressed. They might present with fever, if it's a sepsis, or they might present with tachycardia or low blood pressure or whatever. At some point, they will go from compensated shock to decompensated shock to end organ dysfunction to circling the drain and becoming beyond reach almost, and oftentimes. So when we see the compensated shock, and these are just examples, but you will see a patient who are compensating with hyperventilation, hypotension, and tachycardia, right? They might not be shocky in their hypotension, but the puzzle pieces, like if you take shock index, they might have a high shock index, even though they're still maintaining, they are distressed. And they might not tell you that they're distressed, but their body doesn't lie. They seem distressed. For children, if you have a fever, that you can, like, if you have a fever, then usually it'll become tachycardic, and you can kind of calculate or assume that part of the tachycardia is fever. But if you then lower the fever, or if the fever is inappropriately high, then you'll see that there's something beneath that kind of the fever. There's something else driving that tachycardia. It's a compensation mechanism, and it's often hard to tease out sometimes in children, because they will compensate with their palpitations or tachycardia, not with their shock, or not with the blood pressure drop, not until they're totally decompensated, right? For children and maybe young adults as well sometimes. Yeah, so they compensate, and young people compensate for a long time until they suddenly fall off the cliff. And it can be hard to tease out sometimes, because elderly as well, they might compensate, but if they're on beta blockers, they might not get a tachycardia. It might not have a fever when they're when they have a sepsis. 1 in 3, I think, of elderly with sepsis don't have a fever, so they might be hypothermic. Or they might be normothermic as well. But then you get to decompensated shock, and I have put in lactate here, and I might not I'm not an expert on this, but experts may not agree here. But at least if it's ischemic lactate, then maybe you might have microcirculation problems, such as skin that is cold and clammy, especially if it's both the hands and the feet, or the hands and the knees, and not just the hands. Then you begin to really see the shock index that is high, and then you might have confusion or low GCS, and you might, if they're really bad in a bad way, you have bradycardia, and you might not have a pulse ox read because the map is so low, right? So they might go into a cardiogenic shock after a while with this, or some other bad, like circling the drain kind of thing. So when we look at our patient, it's a good thing to see, okay, we have a C problem in A, B, C, D, E. Okay, is it compensated or non-compensated? So right now it might be compensated, but if they keep on going, it's just like with the work of breathing in B, even though they have a saturation of that's quite high right now, if they have a high work of breathing, they might not be able to keep up. The same way with the C problem, they might not be able to keep up here. So we need to kind of help them before they go over the edge. And again, and as a theme that will run through this shock part of the lecture, looking at the entire thing is important, more so than just one value. So just lactate is not important. Just hypotension is often not important. It has to be seen in the context, of course. But for shock diagnosis, you need oftentimes like both the pretest probability and several puzzle pieces and a trend. So how to diagnose shock, and this is also from the IPCC, Josh Farkas, who's amazing, right? So there's no single diagnostic test for shock. Patients with various forms of shock will present differently. Nonetheless, there is a constellation of findings, and this constellation is something I've talked about a long time, right? So pattern recognition, and which often occurs in the context of a shock. And we need to be taught this kind of pattern recognition in different states of shock. as patients accrue many of these features, the possibility of shock should be seriously considered. Exactly. So this it's pattern. It's constellation of puzzle pieces. And as Gary Klein, one of my favorite people in this kind of field in decision making and psychological, like cognitive psychology, talks about it's not just about finding the puzzle pieces, like putting the pieces together. That assumes that you actually have a puzzle that you know what will end up being. A more appropriate analogy he would suggest in his books is that if you like the diagnosis process is more like throwing maybe 5 or 6 puzzle pieces together or puzzles together and then shuffling them and then trying to find out which puzzle you have to solve. Puzzle number 3 of these 6 puzzles, which pieces belong to that puzzle, and can you find the pieces quickly enough and get a kind of read of what is going on. That's because it's not just about finding the pieces, it's knowing which pieces actually matter and which pieces don't matter. But but this shock is pattern recognition. What is and then it's about trends. It's not only about absolute values. So you might have a blood pressure that is 100. That's good for now. But if it was 140 in pre-hospital setting, and now in 10 minutes it's 90, then it's trending down. And that's not too good, all right? Especially if the pulse is going upwards, and other features are becoming worse. So we need to look at the trends more, at least as much as the absolutes. Okay. And context is king. Okay. So again, from the IBCC, we have just an example of how to shock patients look differently. So the septic patients will generally look sick. They will look, that's often our picture of a shocky patient, right? So they're tachypneic, they're delirious if they're end organ failing, they're febrile or toxic appearing. They might be flushed and warm on the extremities because they're vasodilated usually. That's why vasopressors are usually a good choice in these septic patients, right? So you get the stressed volume, and we'll talk about that later. And they might have an initial normal capillary refill time, but they will soon develop, it will become worse later. If you talk about the pulse pressure, the difference between the systolic and the diastolic, I don't use that too much, but they seem to be quite happy with this measure in other countries, so I might need to use it more, or maybe just a Commonwealth kind of tradition. I don't know. Then they will usually have a wide pulse pressure. These heart failures patients, on the other hand, they will usually look quite normal. They will be speaking with you oftentimes, and but they will be quite cold both in the upper and the lower extremities, and they will often have this poor capillary refill time, and they have mottling, right? Okay. Even so, yeah. And some of these might have normal blood pressure, especially the heart failure patients, but they will be shocky anyway. Right. So which puzzle pieces are we looking for here? Which tests, despite the holistic kind of entire picture of the patient, which is like a thing in of itself, then if we pick the pieces apart, then what are we trying to look for? Well, we're trying to look for hemodynamics, right? Again, trends are more important than absolutes, but in general, if you have a hypotension or a MAP pressure of below 65, or maybe 60 to 65 millimeters of quicksilver, if you have tachycardia, if you have a shock index, even you may use the perfusion index. If you have a diuresis of below 0.5 milliliters per kilo per hour, T is hour in Danish and Swedish, over a period of time, maybe a few hours especially. And if you have microvasculature, that is, if you have a problematic microvasculature, meaning that and this might not be exactly microvascular, but it's overlapping with macrovascular, so I would say, like perfusion of the like capillary beds, and so it's like, so the CRT, the capillary refill time of 3 or more, especially if it's above 4 or 5, because there's a inter-rater reliability on that. If there's a perfusion index of below 1.4 to 2.2, and if they're mottling, if they have cold hands and knees, because lots of people have cold hands once they come from the ambulance, but if you have both of them, like above and below the vena cava, or the superior and the inferior vena cava, kind of, then it's something to be worried about. Then you have the scores, and some of the scores have gone out of favor. The Q-SOFA has gone out of favor, and it's no longer recommended by the surviving sepsis. So these are the sepsis scores. I talked about the shock index as well, which can be used more broadly for shock. There's something called the rabbit score for bleeding, I think. There's different scores, but most of these scores have never been tested for superiority against clinical gestalt. And the SOFA scores and the SIRS scores, especially the SOFA score needs blood samples to actually be scored, such as bilirubin, and it's not always that we have that in the emergency department with old patients. But we can take them, we can score them, and usually we'll get this test after a while, and then it's too late, right? So scores are maybe not too great for the emergency department, I would say. But it might be good for teaching you gestalt of how some of the features of these patients might look. And you have biomarkers. There's more than just lactate, and lactate is kind of going out of favor especially as a resuscitation guide. Like going for a normal lactate is not necessarily, at least after it's gone. If you have a really high lactate, like 12 or 10, right, then making that go down is probably a good thing. Not because the lactate is dangerous, but it's indicating something dangerous or might. But then it goes down to maybe 4, and if it keeps being at 4 for a while, then according to Josh Farkas, we probably shouldn't over treat people to get below the normal level. It's probably fine to it shouldn't be a marker after that. It's not necessarily true that having that amount of lactate is dangerous for the patient. Maybe we should have some ice in the stomach once it's gone down from the high peaks. And you have in organ failure, we're looking for AKI, diuresis, of course, as we just talked about, delirium, confusion, cardiogenic shock, or other failures of your system, such as the liver failure, Again, and we talked about the trends are more important than the absolute levels, right? So if it's going down, then it's over time, then it's, even though it's not absolutely abnormal, then it might be still important. And if you have an absolutely, like if you have a mapped pressure of 60, but all other feature looks good, then maybe it's not too bad. Especially if they're still diuresing. They're still like someone who you have to keep an eye on, but they're not like everything has to be in the context, right? Going into this about capillary refill time, because after the Andromeda shock trial 2, there's been a lot of talk about CRT in almost all of the foam outlets in podcasts, and lots of people have given their advice on this. And I'm, again, no expert in this, but some people like First 10EM, Justin Morgenstern, are a bit conservative about these things, and me and him are usually in agreement with most of the things, evidence-based wise. And EmCrit and Scott Weingart and Josh Farkas are more optimistic about this evidence. I'm not sure, but I don't think it harms to use this marker. There's a lot of literature that is using this marker, and it seems at least there's other markers that we're using that are probably worse, like lactate. So it's part of the puzzle, right? But just like all the other pieces of the puzzle, we probably shouldn't put too much emphasis. The argument emphasis on this, the debate goes whether, like, how important of a puzzle piece is this, and should we guide our resuscitation towards normalizing this? And that's what they did in the adrenaline shock trial, and I haven't done a detailed read through of that. So I'll advise you to go to EmCrit and Justin Morganson's first CDM like views on this to get a like balanced view on the studies. In general, if you need to do the CRT, according to Just Fargus's blog, after doing the adrenaline shock trial, you'll have to compress the fingertip for 10 seconds. Like, you can do it centrally as well, especially if the fingers are cold. Then you could, but yeah, when you might get a false positive CRT, but you can do it like peripherally, and then release the pressure and measure the time until the fingertip appears to be the same color as the adjacent finger. So you push, and Just Farkas and Weingart goes into details about whether you need a glass to do it and whether you need a stopwatch, just to optimize the inter-rater reliability, because the inter-rater reliability is not too good on it. So we'll go through that. A normal capillary refill time is below 3. It suggests adequate perfusion. Such patients may be harmed by ongoing fluid resuscitation. That's the Andromeca shock trial, kind of like, yeah. And then you have, yeah, the Andromeca shock trial true was, they said that if there's a CRT above 3, then that indicates need for intervention fluid or vasopressors, and intervention should in 85% of the patients actually make the CRT trend down. So if the CRT is close to 3, though, this is a puzzle piece, and if the puzzle piece is if there's a 5 in CRT, then it's probably very significant. But if it's only a 3.5, then there's an inter-rater reliability around 3, and then plus 1 to 2. So the further away it is from 3 or above 3, the more significant this thing probably is, and the more significant you have to take, or more aggressive stance you have to take to treat it. So it's kind of like lactate. If it's really, really high, then we want to treat it down. But if it's just, and then when we treat it, if it's just around 3, and the lactate is just around 2 to 3 or 4 maybe, then we've treated probably enough. But there's a lot of debate about this, so please check out the primary sources. Then you have mottling. Check for mottling. Check the knee temperature and the hand temperature. If they're both cold, then it might be more significant than just the hands, right? Then there's the perfusion index, and you have, when you do your saturation reading, then you have PI up here, and PI, according to Fargas, is almost or similar to stroke volume over vascular tone. So if you have a high vascular tone or a low stroke volume, then it will go down, right? So a normal one is 0.2 to 10%, and it might be false low if it's cold or if you have a cold hand. But below 1.4 to 2, it insinuates bad perfusion, and it's correlated with the CRT of about 3. What you could do sometimes is, in general, you can do leg raise tests, and if it increases the PI by 10 to 20, then they might be fluid responsive, right? The leg raise test is something that is used in a lot of literature the last couple of years, and you could use it as a kind of, instead of giving the patient a bolus, see if they're responding by blood pressure or a perfusion index once you raise their legs or put them in Trendelenburg, and then you'll see that it's again, this is being fluid responsive is a complex thing. You can just read the fluid responsiveness blocks on EmCrit as well, but but that might indicate that they need fluid, or they are fluid responsive. And I guess but going back to fluids, it's important to say that vasopressors for the right patient is becoming more and more important earlier on than we previously have thought, right? These 30 milliliters per kilo of fluid that is giving the first maybe hour or two. It's not necessarily bad in most patients, but beyond that, at least, it's time to use vasopressors oftentimes if there's no response at all, or if they're becoming worse, especially. But you might even earlier, like you might be wasting your time with fluids as well. It might be an opportunity cost, or like a nappy for you. It's just, oh, we'll just give fluids when they actually need vasopressors. So some of these really sick patients do need something else earlier on than just fluids. Yeah. Okay. Lactate, another concept that we just talked about. I just wanted to go through this excellent kind of graphic presentation. It's in Danish. We used it for a book. I've used it for lectures before. If you want a really detailed read through of it, then please check out Cliff Reed's read on this lactate thing on YouTube. He has a great read through about it. But in general, this is the Krebs cycle, and I've no I have no memory of the details of the Krebs cycles, but in general, glucose is made to become pyruvate, and then pyruvate can either be lysed aerobically, becoming acetyl CoA, or it can be anaerobically metabolized, and then it will make lactate, and lactate is metabolized in the liver. So why can you have lactating increase? Well, if you have a liver disease, then you will oftentimes have high lactate at baseline, because you're not breaking down the lactate that is always being made in the body in some shape or form, right? These pathways are not singly like, it's not only one pathway in the body. Usually it's produced, like both things are produced continuously, and the steady state of lactate in liver disease might be higher for this reason. Then you have your glycolysis, this process. If this accelerates, then there will become more coal on the fire. Then you no matter how much there is in both these pathways, it will become more in both of these pathways, right? So you will get more lactate, and that's what we're seeing when we get people salbutamol, or if they're, for instance, if they have a high adrenaline response, such as if they're in sepsis, then that they will give them an adrenaline response. But also if they're vomiting, if you're giving them like pure adrenaline as a part of your sepsis treatment, and that lactate will increase as well. And that doesn't mean that they're being under resuscitated. That just means that the lactate has different reasons for increasing. It might have begun as just pure ischemia or something else, but now with the adrenaline on board, it might be something else. So it just, yeah. Then it might be thiamine. If you have a thiamine deficiency, if you're alcoholic and have thiamine deficiency, it might be liver disease, high lactate might be liver disease, or it might be that you're short in thiamine, so you can always treat that as well. And then you have the anaerobic pathway, which is what we're kind of afraid of and often think lactate is only represented by. That's the hypoxia, or for instance, not hypoxia, but hyperperfusion of tissue, such as ischemic bowel. In certain circumstances, I know some trauma surgeons are going really hard on lactate as one of the main biomarkers for going to surgery. I've not read up on that literature, but it might be that lactate in certain scenarios, such as trauma, is a more significant marker of badness than it is in such like shock without trauma. Yeah. Then you have, of course, in the cell you have mitochondria diseases, but also where carbon monoxide, cyanide poisoning, metformin, and toxic alcohol and so on can have a say, and that will increase lactate either falsely or truly. And hyperventilation can give you lactate alkalosis. Yeah, and then sepsis has several things have not multiple things here. So like sepsis might be hyperperfusion, but it might as well also be just adrenaline. Exactly. All right. Another concept in shock and in general in medicine, like if we according to Anders Ericsson in Peak, someone who's an expert at something is someone who has developed better and better mental models, right? So our mental model says something about how we understand something and how we apply that understanding to the real world once we're in the clinical situation or in that situation. So, for instance, to begin with, our blood, like if you have a C problem, we have a patient who we think are in shock, then it's, well, low blood pressure, then we'll get fluids. That might be a novice mind map, a medical student's mind map of this, and that's fine. My mind map is here, and I'll go through that in a little while. And that's the four, you have different mind maps. There's the pump, the tank, and so on, and then there's this one, which is kind of similar to the pump and the tank. But then you have something like Sarah Krager's mindset, which is the 3 pressures model, and it's much more sophisticated in many ways, but maybe too advanced for the ED. I'm not sure, because many of these concepts also has to be context appropriate, and we don't have A lines in them. We don't have all of these measures necessarily in the ED, but with a patient that has already gotten fluid resuscitated and maybe also is already are on their first pressor and they're still shocky, then this becomes much more of a needed mental model, I think. I'm not saying that it is useless in the ED. It might be very useful in certain circumstances, but in general, I think Sarah Krager is an emergency physician and an ICU doctor, so she has like a foot in both camps. And one of the things that this mind map is good for is giving furosemide, for instance, for a patient that is in shock, because maybe it's not the forward pressure, maybe it's not the backward pressure, but maybe it's the colloid pressure or the pressure from outside that's pressuring all the capillaries. Because even though the patient has a high pressure, then they might still be hyperperfusing. Microcirculature is still hyperperfusing, and they still might be in shock. So there's certain areas of this model that might be applicable to emergency medicine, but in general, depends on what you're using it for. So causes of shock. How do we, once we think, okay, this patient is in shock, how do we move on and say what kind of shock is it, and what's the treatment? Like, the reason why we want to categorize the shock is because we kind of need to know. We assume that there are specific treatments for different kinds of shock that we need to do, and then there are. So how can we do that? Well, clinically we can. We just went through the clinical part. ECG, blood gas and blood samples, and then POCUS. There's the Rush exam, for instance, and you can use a transthoracic echo as well, maybe. That's part of the POCUS thing, right? No matter what, when we have a shocky patient, we do gather our data. This is also from Sarah Krager. We have this, in general, in the critically ill patient in the resus bay, we have this iterative hypothesis testing kind of way of doing things, where we don't have time to gather all of the data, and so we go on the low amount of data that we have, but we try to get as much good data that we can to get a good picture of the patient, right? And to get this pattern. What is the pattern? Because we can treat the patient generically, like low blood pressure equals fluid, but if we keep treating a patient with fluids, then we might miss the anaphylaxis, right? And they will not need like an anaphylaxis patient will need adrenaline. So you do have to have the generic ABCD information gathering, but you also need to have this syndrome management, like more specific management of what do we do with this specific patient with this specific problem. Okay, so you try to like going through ABCs and gathering this data, you kind of get an hypothesis, and you try to treat the patient according to that hypothesis. And if they don't get better, right, they don't meet your kind of criteria for getting better, that might be getting better CRT, getting better blood pressure, getting better mentating or whatever, then you'll have to adjust your hypothesis, or maybe become a little bit more certain with, like, maybe you don't need POCUS, you need a CT to be sure all of these things are good with the patient, and you need to just think one more time, right? So we continuously revising our hypothesis as we go along, and if it's going the wrong way, we always try to like expand. Am I missing something? We need those mental maps of how have we, even though it looked like a pulmonary embolism, this patient, maybe it's a different kind of shock, or maybe it's a simultaneous kind of shock that we need to approach differently, right? And then maybe sometimes we need definitive diagnostics, right? So maybe is the patient stable enough for doing the CT scan, and the creatinine and CIN, like contrast-induced nephropathy, is that's probably a myth at this point, right? Or in most patients, and if they're not stabilized, for instance, in trauma, then we'll have to go to the operation room with these patients, right? Just to show, like, Rebel EM made a analysis of this, Basmai 2024 meta-analysis on doing POCUS for shock and whether it helped with mortality. And actually, there was a significant mortality benefit in this meta-analysis, right? So there was an improvement in mortality with the ones that were assessed with POCUS as opposed to those who were not, and all of the other secondary outcomes were trending on the right direction. So this seems like there might be a benefit of doing this. And the Rush exam, this is from the POCUS Atlas. So the Rush exam is, of course, doing the heart, the IVC, the Morrison's pouches, the aorta, and then pulmonary. So get like the what you call a ultrasound footprint kind of, or POCUS footprint of doing that, kind of knowing, okay, we have the entire picture. What is happening? What is the cause of shock? Do we have enough puzzle pieces for telling whether they're fluid responsive or not, and so on. Here's from IBCC, the bedside approach to undifferentiated shock, to kind of put them into these categories: distributive, such as anaphylaxis and so on, hypovolemic, RV failure, tamponade, tensive pneumothorax, high airway pressure, like high intrathoracic pressures, LV failure, and then volume dysfunction. And what the kind of the POCUS findings might be here. So this is my mental map, and that is these areas, right? So you have cardiogenic shock, you have hypovolemic shock, you have cardiogenic shock that might be both right or left chamber, obstructive shock, vasodilatory or distributive shock, and dissociative shock. And once I have a patient with a C problem that is not responding in a way that I like, some of them are obvious sometimes, but sometimes you need to go like through this every time with some patients, right? So, and especially if they're not doing too well and you're not responding to your treatment, then you have to think about these. Are there more than one of these? Oftentimes there might be more than one. In sepsis, there might be both hypovolemic and distributive, but it might also have some amount of cardiogenic shock or even obstructive shock sometimes if they have a PeriMyocarditis, that they have fever or kind of vasodilatory and septic. Oftentimes there's several components to these. Like if you have a septic patient with Addison's crisis, and it's also like vasodilatory, maybe hypovolemic for vomiting, and then as well they might have So there's different kind of then you have dissociative shock, which is low blood, like anemia or carbon monoxide poisoning and so on. Even though there's blood coming to the tissue, it's not oxygenated, or there's not oxygen being delivered because the mechanism of delivery is not there, even though the pressures are. Right. So that's dissociative shock. So bleeding, blood on the floor or 4 more, checking those compartments. And of course, the history is usually helping if it's a traumatic bleed. Do the responsive fluids? Is the like IVC is definitely not the only thing that you have to look for here for fluid responsiveness. Fluid responsiveness is complex, as I said, but IVC might be a smaller and smaller puzzle piece in this, but there is somewhat still a puzzle piece. Then cardiogenic, right? For vasodilatory, for obstructive, and for dissociative, right? So if you have bleeding shock, there's 2 things you need to do in bleeding, right? You have to stop the bleeding, and you have to like resus the patient so that they get their blood products, and depending on how ill they are, you do an MTP, massive transfusion protocol. Check out EmCases podcast on that, or on the MTP. And the 7Ts they've made with petrosoniac. Otherwise, you'll do as Sarah Krager advises. Oftentimes, you can just order 2 units of blood, and that's also petrosoniac who says this. And after a certain amount of units, maybe 2, 3, or 4, if they're still not responding, then you'll activate. Or if there's, of course, if they're not responding, or if they're just responding but they're not responding in the way that you want, then you might activate the massive transfusion protocol. So that's what you do in bleedings, right? And then there's certain bleedings that might be different than others, like upper GI bleedings. You shouldn't over transfuse these patients unless they're in like peri-arrest. Especially if I'm talking like variceal bleedings. There might be certain treatments that are important for certain bleeds, such as for variceal bleedings, upper GI bleed for varices. Antibiotics is the most important mortality benefit. Whereas something that we often give, omeprazole or PPIs, don't have any strong evidence at all for them, right? So look up on the literature on the bleeding things there. Okay, then cardiogenic shock, it might be right chamber or left chamber, and Sarah Krager has been a proponent of talking about the right chamber. Check out her lectures on this and how to, if you have a big right-sided pulmonary embolism, then you should probably not be using anything that increases the pressure on the intrathoracic, like the intrathoracic pressure. So you don't want to intubate these patients if you really don't need to, because that will increase the pressure of an already strained right chamber, and it might tip them over to cardiac arrest, or will probably. Same with NIV, NIV, or BiPAP. What you do need is something that lowers the resistance in the lungs and keeps the vascular resistance okay. So that noradrenaline is an okay choice, but you might also do others, and Sarah Krager goes through the details of this. Also inhaled nitric oxide or different pulmonary vascular dilatory things that are not usually used in our clinics, but it's a thing that you might think about. Yeah. And so on and so forth through the shocks, right? So you try to gather your data and see which shock is most likely in these cases. How do we treat these patients? So there's also a toolbox of treatment. So fluid responsiveness, again, Vanguard has an entire thing on this, and there's lots of details and nuance here. One way of doing it is giving at least a bolus and seeing if they're, or lifting the legs as we talked about, seeing if are they responding or not. But you might pick up more puzzle pieces through POCUS, through the clinical scenario in general. And yeah, I'm no expert in evaluating this in general. It's hard, and I've been on these step down units for a while at least, and it is hard to assess the fluid responsiveness. Weight over time is often one of the better measures as well. But again, check out Scott Weingard's on this. Vasopressors, noradrenaline is never wrong. That's true. It's usually the first best choice. But if we, as emergency physicians, if we can't make it, if we for some reason cannot, our nurses don't know how to do noradrenaline right now, then we'll have to push dose pressors until we can get that noradrenaline, right? So, and push dose pressors, I have an entire video on it, but in short, I can in the next slide, I can go through it a little bit. But in really shortly, it's just yeah, we'll do it in the next slide. And then you have to treat the underlying cause. If it's sepsis, then you'll do antibiotics and treat the focus. Like if there's a focus in the skin, then you'll add meropenem or treat with meropenem or something similar, and then also clindamycin to do the toxin. Like to treat the toxins, and then like if it's bleeding, stop the bleeding and try to like resuscitate the patient so that you get them fueled up with blood and blood products and so on. And then if you have refractory shock, then you should consider there's a long list of, if you have a refractory shock, what you should do. You could give them hydrocortisone because a lot of these patients have Addison's or thyrotoxicosis where it might help. Sorry, not thyrotoxicosis maybe, but maybe more like myxedemic coma. EmCases just did a great series on these diseases, so check that out. Do they have a toxicological reason why? Early on, they like for a few years they talked about methylene blue. I'm not sure the evidence is too strong on that though, so probably not. And then there's this thing about if you have a patient who is in shock, but you don't know what the reason is for the shock, then Weingard's rule of thumb is you should treat with antibiotics. All right. You can also sometimes treat with adrenaline because an anaphylactic shock doesn't have to have any that many features of anaphylaxis other than an agent, and you might not know the agent that has caused this, and then they're just shocky. Those two components might be the only ones according to the World Allergy Organization, WAO. So you might consider especially treating with antibiotics if they even though they have febrile, but you don't find any other cause for their shock. And then sometimes, but not frequently, consider anaphylactic care. And then you have to think about where are these patients going, and do they need what's their goals of care? Are they appropriate to step up units or not? Because that's one of the hardest part. If you have a patient who are kind of you're not doing everything you can. They're not intensive care candidates, but they're not either like someone you just want to stop with right now. They get the chance, and which kind of department wants to take this chance, like with a semi-intensive plan in a normal ward unit for these patients sometimes. And you can do it, but that's part of the how far do we go with this patient kind of talk. Here is a for sepsis. One of the newer Josh Farkas productions here from 2025. And for sepsis, he will say, and you can let him go through it and him go talk about it. But the initial management is up here. Then is the perfusion adequate? And he'll use these 3 parameters. If there's adequate perfusion, then yes, and continue the therapy and continue to monitor the hemodynamics and perfusion. If not, then you'll do these things that he says down here, and depending on which one fits, then you'll do that thing. But yeah, check it out yourself. Yeah, we talk about Furix or furosemide for shock, and this is a Sarah Krager model, just saying that there are some things of this that we might be able to use in the emergency department, and I think we often are too map focused. We should think about shock as hyperperfusion. Even though the blood isn't reaching the capillaries, there might be too much pressure here for it to actually be being perfused. So check out Sarah Krager's amazing lecture on the shock model, and you can let her model be taught by her. Then you have, but there's one concept that is like that I borrow from Sarah Krager here as well, but that is like in the literature, and that is the stressed volume. So if you put in water into a balloon, then it'll take a long while before it actually stretches and becomes stiff, and then after a while it'll become then it'll become stiff, right? But the problem is, like, if the patient's vessels is this balloon, then if we need to pull in pretty large amounts of volumes before we actually get a pressure up. And what we if they're vasoplegic, but what we might be able to do is if we just put on a little bit of vasopressors so that it's the stressed volume, right? Then we might be able to move this curve, and then from here to here, so we don't have to drown our patients, but give a little bit of vasopressors to begin with, and then the volume needed is probably not too high to actually get to actually get the blood pressure up. So that's one of the physiological arguments for giving pressures earlier on with a lot of patients. Okay, that's it for the shock part of this. Now we'll go on to chest pain. So chest pain, I usually there's different descriptors classically, like different illness scripts in chest pain have different presentations, of course, and different, like, some of these, like the classical presentation of these are usually quite distinct, but there's big overlaps between these, so much so that as we'll see, we probably need troponins of all, especially new chest pain patients, with few exceptions, right? And when we're talking about diagnosis of chest pain in our patients, then we of course need to talk about the probabilistics. I've already done lectures on probabilistics. Please check those out if you want to know where you can have a recap. Probabilistics, of course, is you only have a probability of disease. You don't have 100 or 0% of it. Diagnostic tests, they pull up the likelihood or pull down the likelihood of a disease depending on how good the test is, how high or low the likelihood ratio is on them, right? And all things are tests, such as both the things that we think are tests and the things that we might not think are tests, such as questioning and quality of questioning, quality of speaking with the patients, gathering, like the quality of the data that we gather and how we gather it, examination findings, blood samples, scans, and so on. A diagnostic test must never be taken out of context. The pretest probability is the context, and as I talked about at length, you cannot interpret a test without the context. Before ordering a test, consider if it will change management, if positive or negative, and if not, don't order it. Fly ahead of the plane, so that if the test is negative, what do you do then? Right? Positive test guides us towards what we want to do. Negative tests makes us we need to think whether we rule out everything we need to rule out or not if the test is negative, such as the CT scan. And to think about that ahead of time is such a powerful thing to learn in emergency medicine. All right. Time critical, not time critical, likely or unlikely. This is the thing that I have done for years, and this is what I usually draw for each presentation. Every time someone consults me, or most times someone consults me, I'll ask, what are the time critical conditions and likely conditions from the history that you gathered? And I need, like, oftentimes there's like, I think this is gastritis. Okay, well, it might be. It's the most likely probably, but that doesn't mean that are any of these conditions over the threshold for working them up or not. And do we have a good test? If you suggest any of these non-time critical conditions, do you have a good test to rule that in so that we can rule these out by ruling this in? And do we think there are more than just one thing going on? Then we can't use that. Then we cannot use that, like ruling this in by ruling this out, because then the sum of diagnoses, differential diagnosis, is not 100% anymore. Then it's Hickham's dictum territory where the patient can have anything like more than one diagnosis. And there are certain groups that might have that. Elderly people usually, or critically ill patients might, or second sickening patients that have a more prolonged thing might have not just pneumonia, but also maybe a pulmonary embolism along with that. Okay, for chest conditions or chest pain, you have your T0, like before we know anything about the time of 0, before we know anything about the patient. Then I usually say there are 6 big differential diagnoses in chest pain patients that we need to think about: ACS, PeriMyocarditis, pulmonary embolism, pneumothorax, like 2 heart, 2 lung, and then 2 miscellaneous, like aortic disease and upper GI. And upper GI might be cholecystitis, might be pancreatitis, might be perforated ulcer. Yeah. And ACS might be everything from OMI to OMI to NOMI. Might be MINOCA, like SCAT. Yeah, we'll go into these. So this is always my list. And after 5 or 10 minutes with the patient, usually you can rule out 3 of these, or maybe 4 of these. Sometimes only 1 of these. Then you'll have a list, and then you'll know kind of what you want to work up. There's very few diagnoses here that I can definitively rule in. It might be disc prolapse with a positive Sperling's test. Might be different things, right? But in general, pushing on the patient's chest is not good enough, because a lot of patients are sore, even with even if they have pleuritic chest pain, they might be sore on the chest anyway, and it's not enough to rule out the different other stuff, even in a young patient sometimes. You probably need at least troponin and so on. Yeah. Looking at this in a graphic way, then we have the time critical and likely, and the time critical and the non-time critical and likely. So this always much more like likely to have these gastritis or miscellaneous things, non-dangerous things for your chest complaint. But there is always, like, we need to consider after doing a history and all with the patient, and like after, like at certain point after the clinical process, are we over or under this with the different, like, 6 diagnoses that we just talked about? If we're over, then we need to work them up actively, right? Or hope that there's something that can rule this, like rule a benign condition in, so that the others can be ruled out. But there are some caveats, right? So the sum has to be 100% to do that. So we know Hickham's dictum, there has to be just one cause of the patient's pain, not 2. And who might there not be just one reason for that? We talked about the critically ill patient, the elderly patients, and the prolonged symptom sickening patients, right? Then you have the highly highly pathognomonic specific ruling in. If you have a highly pathognomonic test for a benign thing, then it's really good. Then you can rule in by ruling out, right? But if it's just a small arrow, just says, oh, the patient got better on a gastric cocktail and they're 60 years old, then I'm not satisfied with ruling that out as a gastritis. Or if the patient got better with nitro, and I'm not good enough with just ruling that out. Like saying that it's just an ACS or angina equivalent. It might be something else still. And then it has to go all the way under the threshold, right? You might have a good test, but it might not. Like if you have such a high probability, if you start up here, if it's an elderly patient, young patient, if it's a young patient down here, if an elderly patient, right? So what might be okay to rule in by ruling out here, like maybe in the young patients, yes, maybe you would say gastritis sometimes after the troponins come back and everything else is okay. But in the elderly patient, you need to be more aware that it really is a high predisposability to begin with in these patients for dangerous stuff. So you begin up here, and it's harder to push this down without more definitive tests. Okay. And the threshold I talked about earlier depends on these things: how bad is the disease that we're trying to rule out, how bad or good are the tests, and so on. Check out SMAC 2016 Casey Parker's lecture on this to get that's where I get this from, this part, and then please check his lecture out on Bayes a Odyssey, I think it's called. Okay, ACS or AKS as it's called in Scandinavian. So the guideline we're talking about here is the ESC guideline for management of acute coronary syndrome. It's from 2023. So that's our main guideline in Europe for this. So ACS has a lot of, there's likely ratio that we should know about. This is part of the illness script for ACS. It's a pain that usually develops slowly. It can radiate to both arms. It's more sensitive. It's a higher likely ratio if it radiates to the right arm than the left. Oftentimes, it's like if you had like this referred pain, which is usually pain within the thorax or the abdomen. If you have this, then usually, then you suspect that the patient will not like be sore when you're moving them. For instance, if you have someone who has shoulder pain, but you cannot reproduce the pain by just moving their arm, then you should be concerned for something within the thorax, for instance, or upper abdomen, such as cholecystitis or so on, but also chest pain, right? When should we suspect ACS? Well, chest pain, no matter what sort, actually. And we'll go back to that. I'll come back to that. 80% of men and women have chest pain. But there's a risk of gender bias in the latest maybe 20 years, 30 years, there's been a lot of talk about the gender bias in chest pain and in ACS in general. And this new guideline talks about, there is, but the main gender bias is downplaying the chest pain of females, as I understand it, and not working them up if they have chest pain. So we should work every patient up, no matter of skin color or whatever gender, if they have chest pain similarly. And biases are hard, and we all have biases. So we need to just be aware of it. Then you have chest pain equivalents, which also should be considered for workup if there's no obvious reason for it. So epigastric pain, for instance, if they have a certain age, then we usually, with epigastric pain, we'll always take a troponin and an ECG. If they are sweating, if they have jaw and arm pain, no matter which side it is, and if it cannot be palpated, like if it's a referred pain in the shoulders, then we should also consider it, right? Then you have atypical. They don't want to call it atypical pain anymore, but around 15 or 20% of all patients will present with ACS, not with chest pain, but there might not, as previously thought, be too big a difference between women and men here. Men could present with this as well, but women might present a little bit more often with this. Earlier we also said the patients who are neurodiverse or neurodegenerative and diabetics with nerve ending problems might also present differently. But women present a little bit more often with dizziness and kind of vomiting, nausea, and jaw or neck pain and dyspnea. This is our guideline in Stockholm for working up chest pain with ACS kind of. If we think it's ACS, so we have the rule out one troponin rule out, TNT, high sensitivity troponin rule out, with if you have a TNT below 5. But if you have it and you present within, I think it's 2 hours, depends, like 1 hour is oftentimes too little. There are some studies from Rick Buddy, at 1 hour troponin might be okay if it's below 5, but in Stockholm we still say like 2 to maybe 3, depending on your pre-test probability, of course. If they have lots of features, you'll take another one if they present within 1 hour, or 2 hours. But most patients that have below 5 can be sent home with just 1 after 2 hours or so. And it might be 1 hour. I have to, something like that. But if they're above 5 and below 14, then you'll have to take a second troponin. We can never make it after 2 hours, but or 1 hour either. But we'll take a second troponin at some point in the near time, right? Especially if they still have chest pain. And then we'll do a heart score, and the heart score has been criticized. We'll talk about that. But if they have a heart score below 3, then usually, we'll send them home for a workup if they need to, but otherwise we'll just send them home and then they have to return if it becomes worse. If they do have a heart score of 4 or more, then usually, like a lot of these patients that have had PCIs before quickly get a heart score of a high score, heart score, because they have an age above 65 many times, and then they might have had some PCIs before and they have some chest pain. Then they easily get the 4 score, right? The 4 points, and then you'll have to talk with a cardiologist oftentimes to send them home, or whether they have to be monitored or not. If they're above, if there's a 3 or more delta troponin, usually going up, but sometimes if the time interval is okay for it, like if they present late, or like, and also if it's going down, but it's harder when it's going down than when it's going up, I would say. Or if it's above 15, then you'll admit them, and then depending on the ECG, we'll talk about OMI or not. Then this might, like, this is for the non-STEMIs, right? The STEMIs and the OMIs, like the STEMI negative OMIs or STEMI equivalents, those you will PCI no matter the troponin, or you at least discuss it with the PCI no matter the troponins. This link down here is the heart score by Barbara Backus and how to do the heart score. Barbara Backus is a Dutch physician who made the heart score, or at least was part of the team who made the heart score. First NEM has criticized the heart score as one like a lot of clinical decision rules has never been tested against Gestalt. So there's critique to be had on the heart score, as many other clinical decision rules. And Rick Buddy, who I think is the creator of the Tmax score in Manchester, Professor Rick Buddy, who has some great content on troponin and ACS. He put out on Signem's blog a couple of years ago the accuracy of different heart scores, and he would according to these, the heart score is kind of in the middle, but his Tmax is one of the better, and he's done several kind of Tmax to improve it, and then the EDEX score as well. So there are different scores out there. It's just saying that heart score is not necessarily the best in all around, but it's a good one when it comes to scores. But generally, scores are not that great. So, yeah. But you have to use what you have at the hospital level in general. Yeah, here's a YouTube video. So who needs a troponin? Well, I would argue that any patient, no matter their age, presenting to the emergency department with new chest pain, there is some literature to suggest that even though we think that we can just rule out patients clinically with chest pain, it's such a high risk feature that unless there's something totally different going on that we can obviously see, then probably we need a troponin in ECG at least the first time. And then upper GI pain, like epigastric pain, and then of course all of these atypical presentations, that's a bit harder, but dyspnea, yes, sometimes they need a troponin. Dizziness, yes, sometimes they need a troponin as well, an ECG, but not routinely. It depends more there. Of course, jaw pain and pain in the arms, of course, yes, sometimes as well. If there's no, and this is like, if there's no other obvious causes, that's the star here. If there's no other obvious causes, and you're not considering that there might be two things going on at once, then yes, then you can do. So Simon Carley from St. Emlyn's and Manchester did a great lecture on SMAC called titled Do Risk Factors Factor? About ACS. And I think this is one of the things that they're alluding to, that in general, you should not be ruling out ACS according to risk factors, right? It's a great lecture. Go look it up. I love it because it's like, what are the risk factors that we're measuring? Like that's the only things that we know, but there's lots of risk factors that we don't know. So we just go on the symptoms already for most patients. Then some risk factors, when we do, like when we check the likely ratios of the risk factors, they're not that important as opposed to the presentation. So listen to what the patient says, do troponins if need be, because here, if you have 0 risk factors, you're almost as risky as, like, this is just almost a line through this, right? There are some studies to suggest that the more risk factors you have as a young person, though, that might be important, as opposed to an older person, where the risk factors might, your main risk factor is that you're getting older, and the significance of the other risk factors like hypertension and smoking and all might go into the background, or might be diluted by the age risk factor. But if you're 30 or 20, then some of the other risk factors might matter, just such as hereditary conditions or hereditary ACS, such as being obese and having diabetes, probably matters a lot. Hypertension, smoking, all of these things. If you have chest pain and have all these things as a young adult, then yes, you have a higher pre-success probability. But over the average, probably it doesn't matter too much, and I would not rule it out if you are not that young adult who does like if you don't have all of these risk factors as a young adult, then you still probably the first time needs a troponin, right? And then, like, do everyone with chest pain need to come to the emergency department? Well, there's of course a certain threshold and a duration of time and so on. But in general, once the patient is at your doorstep at the emergency department, then then you can't really rule it out by just history alone, or at least Rick Body and some other studies suggest that it's not that easy, because or at least if you're talking about maybe not OMI, but you're talking about MACE, which is a problematic measurement, but let's go with it here. If you could, like, it could be ACS, it probably is, or it definitely is, then we're quite good at that, but we're quite specific, but we're not quite sensitive enough. We're not good at ruling it out. So we might be missing 15% if we're not taking troponins on everyone that comes to our doorstep, right? So can you be satisfied with just an ECG sometimes, especially if it's just upper GI pain? I think if you're taking the ECG, you probably need to take the troponin unless, or if you're taking the ECG for ACS reasons, then you probably need to take the troponins as well. That's kind of what this is saying, I think. So this is from St. Eminence as well. AMI is ruled out if no ECG ischemia, and probably not, or definitely not ACS. That has a high sensitivity, but it's not like you probably need the troponin to get under the threshold of 2%. AMI ruled out if no ischemia, and could be, or probably definitely. So yeah. And AMI ruled out if no ischemia and anything other than definitely ACS. That's really not good. So it could be, then you're not sensitive enough, then you need the troponin as well. So who doesn't need troponins? Well, syncope and arrhythmias, right? And there might be different views on this, but in general, syncope without chest pain. I don't think the literature is strong enough yet to suggest that we need to routinely take troponins on these patients, but I might be wrong. Comment me in the comment section. I know they're talking about, and they might be able to prognosticate certain patients in certain risk groups, but I think we might find a few, but we might take troponins on a lot of patients. So I'm not sure yet on that, but I would say so far no routine troponins on those patients, and ongoing dysarrhythmias that are not thought as being ischemic or ischemic induced. Such like you have an ACS underlying that arrhythmia, then you shouldn't take the troponin, because you will have a bump in troponin in most of these primary dysarrhythmias, SVTs or VTs, but it won't matter because it will go down afterwards again. Here is EmCases, who's made these on SVT. Evidence suggests that troponin testing in patients with paroxysmal SVT who presents to the ED with an episode of SVT does not improve outcomes and may increase length of stay. SC depression in multiple incoming SVT and thought of rate related and demanded ischemia unless it persists after cardioversion. So once you're out of it, then take a new 12-lead ECG. If that's okay, then and you don't have any chest pain, send them home without troponin. Yeah. And what about the patient with syncope? It's this is expert opinion though. There's limited value in routine labs for low risk patients, right? While troponins are often drawn in these patients, evidence says that troponin testing should reserve for patients in whom the clinician suspects ACS, and patients in whom labs should be considered, and that's just labs with syncope. That's just not just other things, right? But so the patient presents. This is from Arun Sayal, but this is inspired by Arun Sayal, but in general, it's just probabilistic thinking, right? So a patient presents, and you do a test, and then if the test is positive, then you have a diagnosis, and if not, then you don't have a diagnosis. That's sometimes as how a novice and maybe sometimes non-emergency physician or non-probabilistic emergency physician would think. And to some extent, this is true, right? It's a simplified view. So if you have an injury and you get an X-ray, then it might be positive, and then you have a fracture. And if it's not, then you don't have a fracture. Well, this is where Arjun Sayal would say, well, there's the scared of mnemonic. I've done a 4-part orthopedic lecture on, amongst others, scared of. So please check that out if you want. It's long, but I think it's thorough and useful. And the scared of mnemonic is all the X-ray negative things that you need to think about if the X-ray was negative, but the patient is still high predisposability of some kind of injury. And you can check out the EmCases blog on it. Same goes with chest pain. Like, why do we think that ECG with STEMI, if that's positive, then it's PCI. If that's not, then it's not. Well, if you're using this paradigm, then we'll be missing 25% of the STEMI negative but OMI positive patients that should have been going to PCI, right? The OMI manifesto that came out maybe in 2017-18 from Pendle Myers and Dr. Smith from Dr. Smith's ECG blog. So just as if the X-ray example, you have false positives. Well, if the X-ray is false positive, then you'll be doing a cast on the patient, and no, it's not necessary. That's already that might happen, but okay. For instance, if you then you have the true positives. That's a fracture. That's good. Then you have the true negatives. That's not a fracture. That's good. And you have a missed fracture, and that's problematic if it's a really important fracture, such as if it's an important fracture that you shouldn't be missing. The same thing with chest pain, with ECG, with STEMI, right? If we're using only the STEMI criteria, then you have a false positive. That's an unnecessary PCI. That might be a Menoka or something like that. You have a true positive, and that's where you have the OMI, or you have a clot, and then you need to open. And then true negative, well, it wasn't. There was no need for the PCI. It was something else, not related to a closed vessel. It might also be a Menoka. And false negative, these are the OMIs that we don't want to miss, right? And so in general, Sang-Lemlin's blog made this algorithm, or not algorithm, but like tree of our decisions, and also it's the same as I just showed you, but also if it's a true positive diagnosis, then you have the treatment down here. So if you treat it and they benefit, that's good. Treatment, but no benefit, that's neutral. And treatment and bad outcome, that's bad. Even if the diagnosis is true, but you might have a false positive diagnosis, then you only can either get neutral result or bad result, right? And so on. So it's important to think about this and check out the Sang-Lemlin's decision-making ebook or risk ebook. So my algorithm is like this, right? So chest pain or atypical chest pain, you consider AMI or ACS, and take ECG and delta troponin. If it's negative, then it's ruled out, as we talked about earlier. But it could be negative, and then it's just an unstable angina, and then you might have to admit them, even though all the tests are negative, right? That's part of the ACS still. Then you have, if the troponin or the ECG is positive, right? Especially if the ECG is positive for OMI, then you have the STEMI plus OMIs, and you have the STEMI negative OMIs, and you might have the NOMIs. This is a PCI diagnosis, right? So you have the STEMI plus a NOMI, which could be a Menoka, and you have the STEMI negative NOMIs, which is a true negative STEMI, right? So let's talk about the STEMI positive OMIs. So these are the criteria for STEMI. The ST elevation is measured at the J point. You have the isoelectric line, which is here, right? And sometimes you have a PR depression, making the ST elevation, making it look like there's an ST elevation. So you check the isoelectric line first, and then the J point as the first kind of move here. from the R complex here, or sometimes on the S complex, right? It flattens out. And you measure from here to here. So here's, that might be 2 millimeters of ST elevation. The J point can look differently in different cases. QRS, and then there. Here you don't have an S, so it just goes into from R to a J point. Here you have a kind of a De Vinces looking ST segment. And here you have a J point that is a check mark kind of thing. It's just Osborne wave, I think, a J wave with hypothermia often. Hypothermia. Okay. Then you have chest pains that are STEMI negative but OMI positive, right? And these have been, I've talked about this in a separate block, but in general, yeah, there's ST depression in like you have the posterior STEMI or the posterior OMI where you have the V1 to V4 that is depressed, and if you take maybe V8, V9, the reciprocal ones, then you'll see an ST elevation there sometimes. Then you have your hyperacute T waves where you have a QRS that can be fitted into the T wave, right? So in this paradigm, the ECG is also something that is kind of, you have to think of it as both reciprocals, like is there a reciprocal depression or ST elevation? That's really important. Are there spreaded ischemia throughout the ECG, or is it just one lead? And are there these like relative features? So STEMI criteria are absolute. It's millimeters, right? But it's not. If you have a really small QRS complex, then sometimes even small ST elevations are important, right? So here comes this relativity into it again here. So if you have QRS complex that is so small that but it can fit within the T wave, then it's a hyperacute T wave, especially if it's wide like this. You want to sit on it, right, as opposed to your peaked T waves in hyperkalemia. Then you have then you have some of the STEMI criteria where you have a isolated ST elevation, but there's a reciprocal ST depression, such as 3 and AVL. There's also different ones like the Aslanger and the South African flag that fits into this one lead that is elevated or depressed, but there's a reciprocal one as well. Then you have your OMIs with like the Scarbosa criteria. So you have a left bundle branch block where you have this 3 Scarbosa criteria. If you have one of the 3, then it's significant. So you have your ST elevation or you have your concordant ST elevation in any lead. It might be going up or down. But if you have the ST elevation like here and the QRS goes up and the ST goes the same way and it's more like this looks bad, right? Then it's a concordant ST elevation, and then that's positive. Or you have ST depression. It's a little bit hard to see in this one, but if you have like a notch here in V1 to V3, then that's also significant. Or if you have inappropriate disconcordance. So disconcordance, the R complex or the S complex as it going down is going this way, and the ST is going up here. That's disconcordant, and then you can have appropriate where it's to scale, or if it's inappropriate, then it's not to scale, right? So you have your S measuring from here to and down, from the SR electric line and then down. That's your S, and if that's and then you have your ST elevation here. If the ST elevation is above more than 25% of the S here, then that's a positive third criteria. If you have just one of these criteria, then it's a Scarbosa positive, and then it's the OMI, and then it's an OMI. and it also works with pacemakers. I can't remember if the RBBB is here as well, but the RBBB plus the LAFB, like the biovesicular block, is also significant for this, right? But oftentimes I've never gotten the patients to the PCI because usually they're 3 vessel, like second 3 vessels, these patients, and they're usually, if they have that like RBBB, right bundle branch block with a left-sided axis, then and in the context of either syncope or chest pain, then usually it's a significant finding. Then either for pacemaker if it's syncope, or for ACS if it's, or PCI if it's with ischemic chest pain, but it's hard to get them to a PCI in my opinion, or my experience. Then there have one that is not hard to get to PCI. That's the Winters here, because that's a high lateral oftentimes. So really important to catch. It's like a QRS where the S is moving below the line and it's coming up like this. And then you have here you have the right side, right bundle branch block that I talked about. Here you have what you call a subtle anterior, and there is a specific Metcal calculation help for this in Dr. Smith's ECG block, or in Metcalc made by Dr. Smith. So yeah, you can check that out. And then you have your then you have this spread ST depression with a positive AVR. This is also a patient that is usually sick in more than one, just in one vessel. I've never gotten these to PCI. Okay, and then you have your Wellen syndrome, your biphasic T wave. These are some of the ones that I is most likely to miss oftentimes because they can be quite subtle. But here, up here and down here, so you have up and down. You have 2 kinds of Wellens, right? And this is a reperfusion, so usually the patient don't have any symptoms right now, but if you took the ECG 10 minutes ago, then they would have maybe one of the OMI features or a STEMI feature. And of course, 10, if your patient is unrelieved, there's no pain, or there's still pain, but they don't have any of the specific OMI features, or the ECG's identity, I kind of would say, as Jesse McLaren would teach out, like it's not just about these. You can either learn these patterns by heart, or you can kind of get the ID or the fingerprint of the ECG as a how does the ECG look like? If they're reciprocals, then that's a problem. If there's hyperacute T waves or biphasic T waves, that's a problem. If there's if the ST segment is missing its concavity and is becoming more convex, that's also a problem, right? So there's these like the fingerprint of the ECG is also important, right? So, and if the fingerprint looks bad and the patient looks bad, but it is not quite an OMI, then I'll take an ECG in 15 minutes, right? So, and then see if it's worse then. Then there's the other thing, and that is right now lots of these things is hard to like learn by heart. There's lots of features, and I understand it's hard to learn by heart. Then there you have the Queen of Hearts. You can check out the OMI guide.com. You can check out Dr. Smith's ECG block, or you can check out the Queen of Hearts, which is an app that can be used and bought, and that can kind of assess the accuracy of the OMI criteria for you on the ECG, whether there's a high risk or low risk. And yeah, you still have to be a doctor. You still have to. It's a test with a Likert ratio. You need to assess the pretest probability, right? But it doesn't work in Sweden yet on the Cabrera ECGs that we have. Lots of great resources for this, and these are some of them. Right. Before ending on the ACS thing, we just wanted to talk about myocardial infarction with non-obstructed coronary arteries. You have SCAT. Here's a video by David Carr. But SCAT, spontaneous coronary artery dissection, usually young female patients on some kind of hormone, either usually through pregnancy or postpartum, but not necessarily though. I have had 3 patients, none of them have been pregnant, but there are pregnant cases with this. In my experience, they often present with a kind of an aortic dissection kind of presentation. There's atypical presentations as well, of course, but I've had 3 of these patients, all of them have presented with a kind of, I think it's an aorta, but it just doesn't, it's too young of a patient. It doesn't have the other features, right? But like sudden chest pain that is quite intense in the middle of the chest. They have ECG features that suggests some kind of ischemia, oftentimes almost STEMI or STEMI. Yeah, and they will have oftentimes troponins. But there is one recently that we know that have not had troponin. I think it was SCAT anyway. So there are some cases that don't have it, but yeah. And why do we have to know it? Well, if you think that young people don't have heart disease, that's part of what that can be one of the heart diseases that they have. Takotsubo, I don't want to go into that. Myocarditis, we'll talk about that later. And then peripartum myocarditis, well, yes, they can have that during pregnancy or just after. Type 2 infarctions with anemia. Blunt cardiac injury is an important thing. If you have a relevant trauma to the chest, usually a high velocity trauma, and you have pain, chest pain that is or unexplained hypertension and dysarrhythmia, then you can take the ECG and the troponins, and if both of those are normal, then it's probably ruled out. Yeah, that's what, according to EmCases at least. Then you have traumatic coronary artery traumatic coronary artery dissection. There's one case in the EmCases quick hits that I'm linking to there, where a patient was hit in the chest with, I think, during ice hockey, and they can present late. They can present after days with chest pain, and they're often young, and I guess you take the ECG and the troponin. I'm not sure about the sensitivity and for ruling that out, but I would think that they kind of like this SCAT have some features that you're concerned with. And you have Kuhne's syndrome, which is an allergic myocardial infarction, and these patients need adrenaline. Right. PeriMyocarditis, going on to the next kind of syndrome in the chest pain cavalcade that we're going through here. So PeriMyocarditis, or IMPS, inflammatory myopericardial syndrome, as it's called in the new ESC guideline from 2025 here. And what I want to lead your attention to is that if we forget about myocarditis for a while, because myocarditis usually have troponin, and that's usually not too hard to catch in the emergency department, in my opinion. They sometimes are presenting in a really bad heart failure kind of way, and they're really bad, and then they're really sick, and sometimes it can be missed there. But in general, myocarditis have troponin, and are not usually too hard to catch. At least they will go to PCI, and then they will see, oh, it's a Minoka and it's myocarditis instead. Pericarditis, though, is the thing that is a bit harder, and the old criteria was there were 4 criteria: typical chest pain, auscultation, RUP on auscultation, pericardial effusion, and typical ECG changes. If they had 2 of those 4, then they would be ruled in for pericarditis. But the new criteria here from at least the ESC are like this. You have to either you have a definite, possible, or unlikely rejected or diagnosis. If you only have the clinical presentation without additional criteria, then you're ruled out. If you have one additional feature, or if you have more than one, then you're possible or definite. And what is the clinical presentation? I'll show you the text in the next slide, but in short, it's chest pain that is chest pain that is either pleuritic or it's worsened when sitting up. Lying down, and better when sitting up. It can also be worsened when you're swallowing. And they have said that chest pain or infarct-like symptoms, arrhythmias, heart failure, aborted sudden cardiac arrest as well, or cardiac death. Well, all right, most of them will present with chest pain or something similar. Then you have these extra, instead of 4 similar criteria, then there's an A criteria, which is the clinical presentation. Then you have your additional B criteria, right? You need at least one of these. Pericardial rub, they say it's frequent, or at least 1 in 3, but never heard it. So, yeah. PR depression, or like these are the clinical ST, like the ECG changes that we talked about. PR depression, widespread ST depression or elevation. We'll go into the detail. Then you have CRP, and we'll talk about that as well. Or a new or worsening pericardial effusion, or pericardial edema, or MRI, and we never will do MRI. So it will be these 4 features. But the new one is this, the CRP, right? Otherwise, it's kind of the same 4 clinical features: clinical presentation, pericardial rub, ECG changes, and new worsening pericardial infusion. But now they added CRP, and in my opinion, if you have pleuritic chest pain and CRP, then you might have pleuritis, right? And lots of patients after viral disease or during viral disease will present with pleuritis. A little bit of CRP, and then you have pleuritic chest pain. These patients will sometimes also get a D-dimer and be worked up with pulmonary embolism and so on, but they will also just get this. They will all just, like, the treatment for pericarditis is NSAIDs and abstinence from working out for a month or more sometimes, and that's quite invalidating for patients to do or not do. I'm really worried about, or I'm somewhat worried about that we might be overdiagnosing a lot of patients for just to find a few that might have this, right? So, and what's the risk? I can't find that many good studies on this, like not working out after pericarditis. It's kind of like, I think it's kind of quite few studies that actually inform us about this. And it's kind of, I think it's trying to, like, I think there's a risk here, without having gotten too much into the literature. I think there's a risk here of overdiagnosing a lot of people for just finding like the needle in the haystack, and you might be burning the hay here. I'm not sure, but that's how I'm concerned with the new guideline about this. Red flags for the clinical diagnosis of myocarditis and pericarditis. Well, you can, and oftentimes you will have flu symptoms, pleuritic infarct-like chest pain, and so on and so forth here, right? And here, here's the what they say in the text. So the clinical presentation is chest pain, that's mostly like 85 to 90%. Sharp and pleuritic improves by sitting and leaning forward, exacerbated by inspiration, lying down, and declotization, which is swallowing. Because you swallow, the esophagus moves right next to the heart. That's what they say. Due to the increased attrition between, so we'll go, and then you have dyspnea sometimes, can be reported by the elderly. And then you have arrhythmia, presenting are rare and are usually associated with atrial fibrillation. Then you have the additional criteria. So it includes pericardial rub, ECG changes, new or worsening imaging with new or worsening PECs or pericardial infusion in 60% of the cases, or CRP in 80 to 90% of the cases. Right. And then electric changes. Then they say this, like they kind of hint at, well, if there's ECG changes, then maybe it's actually myocarditis, because the pericardium is electrically silent, right? So there might be some kind of involvement of the myocytes instead. But I don't think they recommend going full myocarditis just because they have ECG changes, but there is something about that here. This is from EmCases before this guideline. So what is it's persistent chest pain for weeks. It can occur at any age, but young, otherwise healthy patients are more likely to have pericarditis than ACSP or dissection, unless they have specific risk factors. Sometimes preceded by respiratory or GI prodrome. It can be seen ACS2, and you will diagnose pericarditis at your peril, as Dr. Smith says. So you should always consider if they have ST elevations that it could be STEMI instead of myocarditis if they have troponin, or pericarditis if they don't have troponin, right? Typically, chest pain from pericarditis pleuritic, central, sharp, and worsening when lying down, sitting up, or leaning forward. That's the same, right? And note this can be difficult for the patient to describe. There's in the EmCases podcast about pericarditis, they suggest that this is a hard diagnosis to make clinically because the classical symptoms are not always explained by the patient. Then they might have fever, pericardial rub. Yeah. Remember to apply the stethoscope firmly, as you can mistake it's moving for a rub. Yeah. Here is the ECG changes, and the thing is with the ECG that they don't necessarily go through all stages, and they don't necessarily have any stage, but they might have PR depression in the first, and this looks like ST elevation, but it's actually PR depression, right? And a little bit of ST elevation as well, though. So here's the isoelectric line, but you can clearly see PR depressed here, but also here in ST elevation. Then stage 2, you might have J point on the baseline before T waves begins with flat. Like here, it almost looks a little bit De Windsor-like. There's also the spodic sign, and I can't remember exactly how that looks, but then you have T wave inversion, and you have normalization of the ECG. It's only found, stage 1 is only found in 60% of patients with pericarditis. Exactly. The temporal evolution are highly variable, and some patients may skip directly from stage 1 to stage 4. Yeah. That's pericarditis. Pneumothorax, I won't go into too much. It's more local for our hospital, so I won't go too much into it. But in general, in our hospital, it's spontaneous pneumothorax. We diagnose it in the emergency department. It's treated by surgery, and it's admitted in medicine. Yeah, because surgery will put in the drain. Traumatic, everything is done surgically. Drains are becoming smaller and smaller. The Brown study from 2020, I think, great Australian from the Gerber and Kaiser group in Australia, made a great study on that. And yeah, the tendency is going towards smaller and smaller drainage if you have appropriate follow-up. First CNM has made great blogs on this. Check that out. And many of these don't even need drainage. The smaller, like the moderate to smaller ones, that's also what the Brown study showed. So check that out. Pulmonary embolism, or LE, lung emboly. There's now a bit old guideline, 6 years old, from ESC, that is widely quoted though, and often quoted on the foam blogs because it's probably the most thorough, I think, on this. So the symptoms of this of PE, it's always like, when do we need actually to do the D-dimer? And we'll go into when it might be appropriate, but in general, the symptoms of PE is mainly dyspnea. You can have pleuritic chest pain, and according to Gary Klein, the creator of PERC and one of the greats in pulmonary embolism, maybe the great, he will tell you that in a recent talk with Scott Weingart here in 2025, late 2025, maybe early 2026, he says that if the patient can point to a specific point on their thorax when they have pleuritic chest pain, then according to his experience, not his research, that's highly concerning for pulmonary embolism and lung infarction. And I recently had a patient that exactly pointed to a specific point with pleuritic chest pain after having cough for 14 days, first mucal purulence and then dry cough. And that the patient had a major pulmonary infarction. So again, cough, even though it might be a pneumonic cough or sound like a pneumonic cough, like 20% have a cough as well. And they might have Hickam Stixum, right? They might have both pneumonia and pulmonary embolism. I often ask them as well, have you been pregnant before? Because the pregnancy is kind of like a stress test for your coagulation system. So if they have never had a clot during their pregnancy and they don't have any risk factors, like they don't have any immobilization or temporary risk factors right now for it, or they're not on the pill or anything like that, then yeah, well, then it's a low risk to begin with. But some, like, they don't have to have risk factors to have pulmonary embolism, of course. So then you have fever. I've recently also had one who had fever 40. But in general, if they have fever below 38.5, then it's not usually pulmonary embolism. Only 7% have it. But again, you can have Hickam Stixum. You might have a sepsis or something else and a pulmonary embolism. So it's not necessarily pulmonary embolism driving the fever, but you can have a higher fever sometimes. This is my algorithm for pulmonary embolism. It's a mixed match of advice from Gary Klein and different podcasts from EmCases and my own experience and so on, and St. Emlyn's and yeah. But so if you have a suspicion of pulmonary embolism, mainly unexplainable dyspnea, more than pleuritic chest pain, but especially if the pleuritic chest pain is on a specific point. But it's not, as Dr. Wells says in his MetCalc comment, it's not everyone with a chest that needs a Wells score. So not all chest pain needs a D-dimer. I would say especially unexplained dyspnea or pleuritic chest pain. These two categories is the ones that I would consider it on. Okay, then if I'm considering it, are they B and C stable? Have they had syncope? Are they irreversibly hypoxic despite oxygen mask? Do they have right heart chamber strain, either on ECG or on POCUS? Then I'll consider thrombolysis, right? So if they have a cardiac arrest, then it's 50 milligrams of alteplase over 10 minutes or as a bolus, and then 50 afterwards over 60 minutes or as a new bolus. It depends. There are different guidelines on this, but mainly 50. That's the main point here. If they're peri-arrest or hemodynamically unstable, then when you're grabbing for your noradrenaline, then you'll be using the then you'll give them thrombolysis as well. And then you'll do the stroke dose with 10 milligrams over 10 minutes or 2 minutes, and then you give them 90 milligram infusion over 2 hours. And if they have a weight less than 65 kilos, then you'll do a max dose of 1.5. Don't do CPAP on these because you will strain their right chamber, and you'll make them go into a cardiac arrest. The same with intubation, right? So that's problematic. So usually if you have a refractory hypoxemia, then usually your go-to kind of thing is just give them oxygen. And if they don't respond to oxygen, then you might give them CPAP or BiPAP, or intubate them. But this is one of the cases like the RSI, and then they die. The hop killers, right? Justin Morgenstern made a great video and blog on RSI, and then they die. So please check that out. But in general, you should not increase the intrathoracic pressure on these patients. So if I have a refractory hypoxic patient, my go-to is now get the ultrasound on the chest, see if they have a big right chamber before you put that BiPAP on. And vasopressors, yes, and like go with Sarah Krager's treatment and her video for emergency treatment of a right heart chamber strain. Right. Then you have the compensated but sick patient. They will give before CT tinsiparin, 175 units per kilo intramuscularly, and they can be thrombolized on this. Earlier we gave them unfractionated heparin, and we still do, but that's like it seems like there's a consensus now, at least expert consensus, that you can use either, and you can thrombolyze on both. Ongoing bleeding. If you have bleeding from somewhere, ulcer or whatever, then it's better to do a thrombectomy on them. Stop the bleeding and do a thrombectomy on them if you can. If not, then it's a risk-benefit analysis whether it's a really bad PE or they're the high risk of bleeding. What is killing them first? And you need to make a choice on that, and maybe thrombolize, maybe half dose, maybe 25%. If you have a hemodynamic unstable pulmonary embolism and an ICH, as we had earlier, there's no recommendation on how to do it, but we have thrombolized these patients before, and we have had survival without major problems in their bleed. Then, according to Klein, if you have a clot in transit, then you have to thrombolize them at some point because it's too dangerous not to. Then, okay, if they're not unstable, then you can check out, are they pregnant? If yes, then you'll use the year score, or if you're uncomfortable using the year score, you'll do the DVT ultrasound and the old algorithm where you try to avoid a CT scan of the chest. But the thing is, with the CT scan of the chest, in EmCases quick hits about radiation doses, they refer to the ASOC 2017 guideline on radiation doses, and it clearly says that you can do X-ray or CT scans on the pregnant patient if need be. They often explain it like this: you have 50 kroners or $50 worth of CT scan during the pregnancy for intrauterine misbildning or mutations, I guess, or problem with the fetus being misdeveloped, right? You have $50 worth, and a CT scan of the chest costs maybe $1 or $2. There's a high confidence interval kind of thing on these because we've never done, for obvious reasons, we've never done RCTs on this, but a lot of the data is from Hiroshima. But it's the best data we have, and it seems like it's not a big risk for that. Then there's a cancer risk for the child, and that's harder to assess, and there's some kind of dose response curve here. So that might be the hardest argument for not doing it, especially if it's the abdomen. But in general, if you need to do it, you need to do it. And then there's the chest or the breast tissue of the woman. That might be that is developing, and that's also an argument not to do it. But most of the times, like if you want to find a different, more benign cause, then that might also be a good way to rule PE out. But oftentimes it's hard to do so, and a lot of patients are baseline dysneic in pregnancy. So I would say the year score is a good one to do. Then if they're not pregnant, then you can do the PERC score. And that's even, like, there's some controversy whether you can use it in a higher pretest probability population like in Europe. That's controversial. But you can use it at least in the United States, where they test more frequently and therefore have a lower pretest probability population. However, in Stockholm it's recommended, so we use it. And it's Jeffrey Klein who's made it. So he in this podcast here from late 2025, I think, he says that it can be used in COVID. you should be careful with using PERC in the pleuritic chest pain patient, especially if they can point to a specific place on your chest where it hurts. And it's not, as I said, it's not fully externally valid in Europe, as I understand it, but it's in many guidelines, and in Stockholm we use it. And if that's negative, if the PERC score is positive, I made an error here. If this PERC score is positive, then you'll do the Wells score. And if the Wells score is low, I don't know whether you do the second, 2th tier or the 3rd tier Wells score. We usually do the 3-tier Wells score, but if you doesn't matter if you're low to moderate presusceptibility, you will need to do the D-dimer. If you're high presusceptibility or the D-dimer, or you have the symptoms for more than 7 to 14 days, it varies on how long you can use this D-dimer and be sure of it. Or if they're on DOAC already, then you'll need to do the CT scan anyway, no matter what the D-dimer says. And the D-dimer should be age adjusted. And if not, if it's positive, then you'll do the CT. If not, then it'll be ruled out. And if the CT is negative, then it'll be ruled out. It's almost 99% sensitive. So that's kind of my algorithm for doing pulmonary embolism workup. And many times in triage, when I'm doing triage, then I can say, oh, this patient has a high presusceptibility to begin with, or the patient has a D-dimer. Or we cannot expect the D-dimer to be good enough. We need the CT scan anyway. Then we can just go on, order the CT scan right away. And then we'll usually just take an ultrasound, check out whether they're B and C stable, and if they have a big right chamber, to see whether they need to be loaded with INOHEP or tensiparin right away or not. Here's the classification of the pulmonary embolism as according to the ESC guideline. You have high risk, which are hemodynamically unstable. So if you're reaching for your vasopressor, then you'll call them high risk. The problem with this classification is that some of these patients that are intermediate high risk, that it only goes on RV dysfunction or strain on CT or on POCUS, and elevated troponin and clinical parameters, right, in PESI score. But it doesn't really, like, if you have a hypoxia that is refractory, then I would usually call them high risk, because you really don't want to intubate this patient and they're still hypoxic. If they have if they've had syncope, is that hemodynamically unstable? Sometimes it's interpreted as it is. So there are some questions here, oftentimes, right? And the really low risk that are PESI 1 score can often go home, but oftentimes we'll sometimes admit them to do it, like they're kind of stressed about the pulmonary embolism thing. So we'll usually, especially if they're young, and we'll do follow-up, but oftentimes they need 1-day admission or something like that. Here's one of these algorithms that like EmCases have done. I've talked about this with Swaminathan, Anand Swaminathan, and so I guess the things that you have to think about is: are they high risk of bleeding, or are they low risk of bleeding? Are they high risk PE, or moderate risk, or everyone else? If they're high risk of bleeding and decompensating, then you'll preferably do a thrombectomy, or you might have to do the alteplase, like in our intracranial bleed, and then you'll do the if they cardiac arrest 50, or if they're not cardiac arrest 10, and then the rest over 2 hours. And then you can always give them LMVH after 2 hours, at minimum 2 hours. Sometimes waiting up to 6 hours is recommended, depends. If they're low risk of bleeding, then you'll just then you might not, then you'll probably not do the thrombectomy. There might be some evidence saying that thrombectomy might be superior to thrombolysis even in these patients, but it's not there yet, as I understand it. So still thrombolysis as the main thing if they're decompensating. Then you have the intermediate high risk group, and that's where there's one big study, I can't remember the name of it right now, but it says that there's no mortality benefit and no lung benefit of doing this thrombolysis in the long term or in the short term for these patients. So you're only doing thrombolysis in the short term, like to prevent them from dying. And it doesn't seem like there's any benefit in that study, but it's somewhat criticized, and they will many of these experts will interpret high intermediate risk. There's a subgroup of these that might need thrombolysis as anyway if they're trending in a bad way, they're becoming worse and worse, or they're refractory, hypoxic, and so on. Then you might, if they're a high bleeding risk, then you might consider quarter alteplase dose or half alteplase dose, and if they're low risk of bleeding. And again here, maybe thrombectomy. Everybody else, that's normal treatment. And here's what they say in the coagulation kind of thing in ESC about whether to use UFH or LMVH. Elimination is preferred over UFA for initial anticoagulation PA as they carry lower risk of inducing major bleeding. But use of UFA is nowadays largely restricted to patients with overt hemodynamic instability or imminent hemodynamic decompensation in whom primary reperfusion treatment will be necessary. So it only says it's mainly used, but isn't necessarily recommended as I understand it. So I usually use LMVH, and the guidelines will probably hopefully change on this when we get further ahead. Okay. Yeah, this is just the hemodynamic unstable reperfusion. Yeah. Should they have telemetry? At least in our hospital, we have a culture of doing a lot of telemetry on these PE patients, and I only found one pilot study from 2022 on this, and it suggests that we shouldn't. I found one guideline on this. The pulmonary embolism patient, this is from British Heart Rhythm Society, suggesting that pulmonary embolism patients should not do low, like the risk of ventricular arrhythmia is low. Cardiac arrest can occur due to pulseless, like PEA. So appropriate patients will require hemodynamic monitoring in an appropriate environment rather than continuous cardiac monitoring. So they don't need telemetry, but high-risk patients will need monitoring, right? That's uncontroversial. But the low-risk patients and the intermediate low-risk patients or moderate-risk patients should not have that monitoring, and no one should probably have telemetry, according to these. And what the ESC guideline says is close monitoring of high risk and intermediate high risk patients with RV dysfunction and troponin. So to allow hemodynamic I've miswritten that, but it's to catch hemodynamic instability and decompensation, right? So, but that doesn't mean that we need to do telemetry on them. Again, you can do blood pressure and you can do other things, right? Saturation monitoring, but you don't necessarily need telemetry on them, and especially not the lower risk ones. So, ECG changes in pulmonary embolism, they're non-specific, but it's important, especially according to Jeffrey Klein, you need to check the ECG always. So if they have the what you call Daniel score or Daniel criteria, if they have S1QT, Q3T3, if they have T negativization in V1 to V4, there's this thing called the Kosuke criteria or the Kosuke sign. If you're kind of differentiating between ACS and pulmonary embolism in your patient, and they have negativization in V1 through V4, and also or they have V1 and inferiorly, like 3, I think it is, then there's a higher risk that this is a PE and not an ACS, because ACS would be 2 different vessels being occluded in, and that's highly unlikely. If it's only T negativization, then if it's 2 vessels, it would be some kind of other ACS presentation, not just T negativization, right? It can also be a new incomplete or complete right bundle branch block, or a new axis deviation right-sided. And of course, if you have a tachycardia without any other explanation, or a new atrial fibrillation, that's also. And then you can do POCUS. There's a great EmCases block on this. We'll do a POCUS block at some point later. Then you have aorta, acute aortic syndrome, or acute aortic dissection. Again, AAD. Acute aortic dissection is AAD. Acute aortic syndrome is with an S here. There's also an ESC guideline on that, 2024. You have type A, which is a thoracic surgeon thing, and then you have type B, which is a vascular surgeon thing. It's quite rare, and just the normal measures of aorta in men and women. I would especially say that here the junction, which is the one we can see in plaques, is around usually 4 millimeters. I can't remember the measures in POCUS. I usually don't do the POCUS on that, but it's around 4 millimeters. That is about 4.5, maybe, is significant for a thoracic aneurysm. Yeah, and here is 3 millimeters. About 3 millimeters, then you have an aneurysm until proven otherwise. So, according to a meta-analysis by Oli, Canadian emergency physician and science guy, and Briggs, and the IRAD, I can't remember what it's called, but it's a huge international organization collecting data on aortic dissection. And then the presentation, typical presentation, is abrupt onset, severe pain is the thunderclap headache of the chest, right? So sudden onset and intense pain. That's the typical. It's usually in the chest or in the back. Only 5% is in the abdomen, but it can be in the abdomen with the chest. However, type B can a little bit more often be only in the abdomen, but only abdomen is only 5% as well in the type B ones. It doesn't really matter whether it's type B or type A. We need to do the CT scan anyway. Tearing and ripping, yes, if they do have it, then it is something quite strongly, but it's not sensitive. Migrating as well. Pulse deficits is somewhat sensitive, a little bit good criteria, and then stroke symptoms is a high criteria. They are often hypertensive, but they might sometimes have shock, and then if they have shock or syncope, then usually they're in a worse way. So the typical presentation is sudden onset, pain described as sharp or tearing, pain radiated to the back or the abdomen, pain severe enough to require frequent and large doses of analgesic, yes. And they might have risk factors, and they might have recent cocaine or amphetamine usage. But the atypical patient, hypotensive with complaints of chest pain, back pain, abdominal pain, and so on. Patient has stroke-like symptoms, so patient with altered mental status or syncope as well. So there's this concept of chest pain plus 1. So if they have chest pain plus something else, then it's a higher risk, like plus neurological deficits. Or if you have 1 plus chest pain, like you have a neurological deficits, or you have a pale leg plus chest pain, then yes, that might be that as well. The thing is, aortic dissection is such a rare disease that, and the problem with the presentations is that it's not uncommon for them to have the atypical presentation. So are we supposed to pick up a atypical presentation of something really rare? That will require a lot of CT scans. And that's the problem with the aorta or the aortic dissection, right? It's such a hassle to find all, and you might end up burning the hay doing that. And that's this quote from, like, there was recently a St. Emlyn's blog where, sorry I didn't refer it here, but they talk about the DASHED, D-A-S-H-E-D, DASHED trial. And the DASHED trial talks about this exact thing. Or the author of that blog talks about this. I once heard a world-renowned U.S. emergency physician say that we should never make the diagnosis of aortic dissection because in the quest to find the very rare cases, we would subject the vast majority to unneeded investigations, concerns, and worry. But of course, the world does not work like that, and neither do we. So I would say we should find the classics, but the atypical presentations, we should probably not. So the elderly patients with the intense thunderclap like chest pain, we should catch that. But if there's a 20-year-old without any acute onset chest pain and no Mafang or Ehlers-Danlos features or anything like that, then it's hard to pick that up. Most of it is gastritis if they have that intense pain epigastrically, and we might end up burning the hay on this. So there's a schism here that's problematic. So the key insights from the IRAD 2022 papers are risk factors are these, as we bicuspid aortic valve, Marfan, and also age with hypertension, atherosclerosis in elderly patients, and a known TAA above 5 centimeters. It says here. Classical presentation is these, as we said, intense, abrupt onset, anterior chest pain, maybe back pain, sometimes radiation to the stomach, a tearing sensation in 50% or migrating. There's a large variation in the presentations. 5% only with chest, or only with stomach pain. Around 5 to 15% are pain-free, but the pain-free ones will often syncopize or have neurological deficits as well. And they might have colicky pain. That's not uncommon if they think it dissects and then it redissects. Syncope is 10 to 20%, and it indicates that there's a tamponade, stroke, or an organ ischemia. We talked about this chest pain +1 or the 1 plus chest pain thing. And the plus here could be strokes, focal deficits, dysphonia, and so on. ECG changes, according to Jesse McLaren's ECG blog on aortic dissection, only 1 in 200 have STEMI, and if they have STEMI, it's inferior. Some of the other sources might say it's a little bit hard, but a few percent might have STEMI. So if you see a STEMI on the ECG, it's probably not aortic dissection. It's probably needs to go to the PCI lab. But you have to be able to convince your PCI doctor of that, and they might not have written that, have read that literature, right? So sometimes we need to, even though there's a STEMI pattern, we need to go to the CCN quickly if it's right down the street, right? So right down the hallway, and it could be SCAT in the young ones, right? As I said, SCAT presentations usually have a kind of aortic dissection kind of like presentation. Then troponin is positive in 1 in 4, and ECG changes are common, but STEMI changes are not common. And then the D-dimer, and then ADDRS score. So the ADDRS score, we'll talk about that in the journal club. But the ADDRS score is an effort to try to reduce the CT scans, and instead we might be able to not do the CT scans in the low-risk population. But the problem, as we'll see with the ADDRS score, is there's not been enough studies on it, prospectively at least, and they're not good enough external validation on them. And there's a problem that we don't know how to assess good enough pretest probability, like who to rule in, who should we use the score on, because in the studies they have a high pretest probability, and then it might be worthwhile, but can we reproduce that in the real world? If we can't, then the score will make it much worse with utilizing CT scans. But if we can, they will be good. So we'll see. Just to remind you, I've made this chart so because oftentimes I hear people mixing up aortic dissection and AAAs, like AAAs, abdominal aortic aneurysm. Both are aortic syndromes, both we need the CT scans for, both are emergencies, but they present a little differently, and they have different treatments in the emergency department. So risk factors are the same, chest pain, or somewhat the same at least. These AAAs are usually older people who have smoked. These aortic dissection can also be younger people. Chest pain is very common in aortic dissection. It's uncommon in both the rapid expanding AA and the contained ruptures. Why haven't I brought in the non-contained ruptures? Well, they die before they come in, so we don't see those. Back pain is common in dissection, especially if you have back pain that you cannot palpate, right? And then you should think about aortic dissection. It's one of the red flag diagnoses. And it's common in as well in here, and it's very common in the contained rupture because it's a rupture to the retroperitoneum. Flank pain is though uncommon in aortic dissection. It's common, very common. It's one of the most commonly missed diagnoses in both the contained and the rapid expanding rupture. Abdominal pain, 5% only abdominal pain. Then you have symptomatic rapid expanding AA. That's common here, and very common here. But you can have abdominal pain with chest pain in these, but you will never have chest pain here. So if you have chest pain, then you'll think aorta dissection, and if you have belly pain without chest pain, then you'll think abdominal aorta. Hypotension, yeah, and usually they have tamponade. These won't have hypotension unless they're like vasovagal or from the pain, but these, of course, will be hypotensive. Syncope, yes, especially in type A. Type B, not so much. Neurodeficits, yes. Royal D-dimer, maybe. ADRS. Royal Pocus, maybe. There's the Casey Parker YouTube channel. They have made a analysis of the, maybe it's something with the P, maybe plethora trial, something like that. Can't remember the name right now, but check out Casey Parker's run through of the trial about POCUS and aortic dissection and the ADDRS score, because that incorporates what kind of test you can do and what kind of POCUS things you should look for. Symptomatic AA POCUS, yes, it's a really good test. Be reminded that maybe 10% of people over 65 of age has AAA, so it might be a false positive. And 90% of them are infrarenal. When you're scanning the aorta in POCUS, the hardest part is seeing the 10% suprarenal ones. So you do have to scan the entire aorta to be able to be sure. And you have contained rupture. Yes, you do have contained rupture here, and POCUS is also good here. But you can't see the retroperitoneal compartment. You're not supposed to see free fluid in the abdomen because they will usually die if they've had that. Maybe they have a small spillage, but yeah. And the risk of rupture, if they have a really big one, if it's just 3 centimeters, just above 3 centimeters, then not too much. But if it's more than 6 or 7 centimeters, then yes, it's really big. But then among asymptomatic patients, the risk of death from causes other than RAA, regardless of aneurysm diameter, was higher than the risk of death from aneurysm rupture. That's quoted from one of the guidelines that I referenced in the previous slide. And so there's this discussion of when to do these operations and whether they should or not. That's the surgical, the vascular surgical problem, vascular surgeon's problem dilemma. Yeah. Take home about POCUS dissection. Well, typical features, I think we should catch those. Atypical features harder. Maybe a DRS score plus D dimer. We'll see in the journal club. And symptomatic AAAs. Yeah, we should catch these. Always think about when you have a flank pain patient. When you have someone presenting with flank pain, then you should definitely think about this. I'll show you in the next slide what I mean. Okay, so last slide in this lecture, when talking about aortic aneurysms in the abdomen, AAAs, it's important to think about kidney stones because oftentimes they present with flank pain, and the main misdiagnosis from flank pain is kidney stones. Is AAAs, right? So, which gets me back to this great image from and my way of seeing this when you have a patient with flank pain. So, first of all, the patient with flank pain, would have any high risk features for difficult stones, uncontrolled pain despite 2 to 3 times NSAIDs. We use ketorolac, but yeah, sepsis, especially if they have there's a risk of obstructed stones, then yes. If they have a creatinine bump, then yes. If they're single kidney, these things will make you do a CT scan to see whether they have a stone or not, no matter what. But if they don't have any of these obvious features, then you'll go to this one. And then this chart is made from a study, or not a study, but a consensus, kind of discussion between different urologists, surgeons, and maybe I think for emergency physicians as well, where they had maybe 36 or 40 cases, where they kind of plotted them out as low risk, high risk, or intermediate, and said who needs the CT scans. Justin Morgenstern has done a read-through of that, and he talked about it in this EmCases block. There's also a first 10 EM block on it if you want to read the case or the study. So in general, it's like this: you have patients who have had no stones before, who has had previous stones and have pain controlled and are young. They generally don't need any imaging. On the other end of the spectrum, you have elderly patients, no previous stones, and have uncontrolled pain. These need CT scans. And in our hospital, I would replace ultrasounds with low-dose CT scans without contrast, right? I would say this is a contrast CT down here, because even though they have uncontrolled pain, so this is the this is your decision. Either you do the low contrast CT scan and then you rule in a benign thing like a kidney stone, and then you probably will rule out in most cases the dangerous stuff if you find a definite kidney stone on the pain side of the patient, right? Even though they're old, then that's what you find. So you might risk it and do that low dose, or you might as well just send them for a contrast CT, and whether that should be with arterial contrast, finding the aortic aneurysm, or venous contrast, maybe not finding the small rifts in the aortic aneurysm. It depends on what you think, right? David Carr made a EmCases quick hits, I think, about we have to remember the renal infarct as well here. So the older they get, the more important it is to kind of do the scan with some kind of contrast to rule out abdominal aortic aneurysm or renal infarct or some other disease that we didn't think about but is diagnosed with CT scan. The pre-test probability of badness increases here. So when do I do the non-contrast CT on these patients? Well, I do the non-contrast CT on the elderly patients when they have had previous stones. So if they have had previous stones up here and their pain is controlled, then I'll probably do a non-contrast CT. And then if that is negative, then I'll have to do another CT scan with contrast to rule out dangerous stuff, right? So I know that it might be a twofer, but if they have blood in their urine, it's a classical presentation that they had previous stones, then I'll probably do that. And one of the elderly, maybe above 65, but sometimes the 50-year-olds I will also do around that, yeah. Then if they have had no previous stones, but their pain is controlled, I'm still on depends, right? But here definitely I will do a contrast CT. All right, the young with no previous stones and pain is controlled, we'll usually send them for a CT scan in 3 or 4 weeks if they don't have any high-risk features, and if they have clear like blood in their urine and clear pain on their side of flank, right? And the same if they're middle-aged and they got around 45, 50, I will probably just, yeah. So this is I will probably do a low contrast CT or not at all, depending on if they're low middle age or high middle age. Again, badness increases with age here, and not everything that looks like a kidney stone is a kidney stone, especially in the elderly and without previous kidney stones. It's a stone I want to see, as I said. Here is a stone I don't need to see. Right. So this is the spectrum, and I use this and as a rough guide to when I want to do a CT scan. And if you don't want to do a contrast CT scan, then you just need to go CT scan, and then if that is negative, fly ahead of the plane. What do I do then? Then I probably need a contrast CT scan anyway. So I don't know the efficacy of doing the one pathway or the other. I use it on an individual basis, and I tell the patient that you might have a longer wait in the emergency department because of it. That's all right for them, usually. All right, that's it for my lecture here. In part 2, we'll talk about the ADTRS score and the advised trial. Thank you so much. Bye. Okay, so this is just an example of how a flowchart might look like. This is one I made from with inspiration from one of our local guidelines, trying to kind of make sense of of what it said. And so if you have a suspected stone, then is there any need for for like some kind of imaging? Yes. If you can do a CT scan without contrast if there's a suspected infected stone. If you have increased creatinine, if you have not insufficient pain relief on NSAIDs or similar, if you're a single kidney patient, then you want to be sure that the other is doing fine. And if sometimes, and this is debatable, but if it's the first time you have stones, it might be a good idea to know whether or not, especially if you do these low contrast CTs. And if you cannot follow up the patient as well, like if you expect bad compliance, like drug user or dementia or something like that, then it might be good to see the stone and assess whether it's complicated or not. Ultrasound is not amazing for kidney stones, but it might be part of your workup, especially checking that they don't have an aortic aneurysm, which is the most common miss in these patients, but also just to check for certain groups like age under 16 years of age and pregnant, where you want to reduce the dose of CT radiation, then maybe you can consider going the ultrasound path. That's what we've talked about in our group, at least. But I'm unaware of the specificity and sensitivity of ultrasound. But in general, I don't believe they are much better than I don't believe that they are better than the low dose CT scan at all, but they might be similar. And if it's a low risk group where you don't think there's any other things going on, where you like want to see the stone or not, then I guess even if the ultrasound is negative, you might have a follow. You might just follow them. If the creatinine is normal and there's no stasis, then you might just follow them. I think there's something called a stone score, and there's different ways to use the ultrasound as well. So you could use it with one of those scores, right? But yeah, and as we talked about, there are sometimes you need a CT with venous or arterial contrast, especially venous contrast. Arterial contrast is usually only needed if you want to find the thrombus, or if you have a suspicion of an aortic dissection. Otherwise, you will probably see the aneurysm and the bleed and all on a venous scan. Even mesenteric ischemia, you might not see the thrombus, but you'll see the ischemia in the gut with a venous scan. So when do you want those or kidney infarction and all? You'll see these in these patients, right? So if you have a suspicion of aortic aneurysm, kidney artery infarction, pulmonary embolism, and so on, because flank pain might be and has been in some of my patients PE instead. So yeah. So again, I have this graph with me here as well, and I just went through that. So just for a reminder of what kind of history points or elements in the what kind of data points are important to think about when assessing these patients. And the general take home is the less stones you've ever had, and the less your pain is controlled, and the older you are, the more you probably need a CT scan, and you need to, there's higher risk of badness. So you might consider doing this if the presentation is not at all typical, then you might consider doing a broader scan with contrast. All right. So if you find a stone, then and this is not exactly this lecture, but I might go through it anyway. If you find a stone, then our protocol would say you have to admit these patients if they're not sufficiently pain relieved, if they have infection, of course, like infected stone, pyelitis, if they have increased creatinine and stenosis, not either or, but both at the same time. If you have single kidney and you have a stone in that kidney system, yes. And then if you're pregnant, yes, because that might be complicated. And if you have urethral stones more than 5 to 6 millimeters, you might also want to. This is controversial because a lot of the patients internationally will just send home. So I don't know the evidence for this. I just know that stones bigger than 5 millimeters will usually not pass, or are lower likelihood of passing than the ones that are smaller than 5 millimeters. Right? So bigger than 5 millimeters will have more difficult time passing, and that might be the reason why we are saying this. But in a in different countries, they might say that, oh well, these patients will come back because they will have pain again, and you might not need the CT scan up front, but at a later stage you might want to. If they are returning to the ED after a couple of days and you still have pain, then yes, then you might want to check them out, right? So, but here we want to do the scan quite early on for a lot of these patients. So even the first time they have stones, and then you might find whether the stone is big or not, and whether it's proximal or distal. And you can follow the flow chart here to see what we want to do with these patients. This is not evidence-based, as I am aware of, but it's more like
it's a mix of some evidence, but also mainly local instructions and what is attainable at our place. So it's mainly made out of three things: whether there's stones and whether the size of the stone, and also how obstructing the stone is. So whether is there creatinine and something like hydronephrosis, then you will admit these patients even no matter the size of the stone. If there's only creatinine increase, then you'll only admit them if there's a big stone. And if there's hydronephrosis, you'll also admit them only if it's a big stone. If there's small stones, then you might just follow them up. This is about, as I interpret this, it's about the likelihood of these stones passing on their own. And they need, all of these patients going home need thorough instructions, and they would need like diclofenac or NSAIDs rectally, and if they don't tolerate that, then some kind of morphine rectally as needed. And if it's not enough with 2 diclofenac, I usually tell them to come to the ED. If they tried one and wait 20 minutes and then try one more, wait 20 minutes, then they're still in a moderate to severe pain, and then come in, because there's a high likelihood that this stone is complicated, and meaning that it either has a creatinine bump, or there's hydronephrosis, or there's some kind of infection, or is higher risk for infection. They also need to know that if they have infection, then they have to come in right away, right? And then you might want to inform them that they need to pee in a sieve, so that you can collect the stone. This is more and more important as if you have more times you had stones, right? So if you're a person who has made a lot of stones in your life, then it's increasingly important to get some kind of analysis on that stone, so that you can get some kind of specific recommendations regarding what your dietary recommendations should be moving onwards. Most of the stones are calcium, right? So, all right. Yeah.